It's my honor to speak about this clinical features and the staging of choroidal melanoma here in this meeting. So I want to emphasize again, uveal melanoma is the most common primary intraocular malignancy in adults. It is also found in Asians. It's a rare tumor in Asians, but the mortality rate is relatively high for the uveal melanoma. You can see that the incidence in the USA is about 5 cases per million population, and in Asian is about 0.3. But we also share some similarities because it is also more common in males, in Asians, and some differences are the age of diagnosis. In Caucasian, the mean age at the diagnosis is about 55 years old, and in Asian is about 10 years younger, about 45 years old. And then the 5-year survival rate is also different from the reports from the Eurocare is about 68%, and in the United States and in Asian is about 85%. Okay. First, I would like to, you may know the AJCC classification for both the iris melanoma and also the choroidal melanoma, but I want to say it is a standard way to describe the staging of the tumor. So I have to spend some time to talk about this classification. Because iris melanoma is relatively rare and it accounts for about 5 to 10% of the uveal melanoma. So in this picture, you can see a case came in with decreased vision for about 6 months, and she had cataract surgery 3 years ago, and you may appreciate the diffuse hyperpigmented lesion. And also, you can see nodules at the superior temporal part of the left eye. And also pigment on the intraocular lens with under control intraocular pressure up to 30 millimeter mercury. So in this classification, we would say the tumor is a T2A tumor because the tumor involves the ciliary body and with increased IOP. So let me mention about the T1 tumors are limited to the iris. T2 tumors involve the ciliary body and choroid above, and the T3 tumors involve ciliary body, choroid, and with extra to the sclera, and the T4 tumors have extra sclera extension. So we do not have to memorize it, but just keep in mind when you see the patients, you can make a better classification. Yeah. And for the posterior part of the uvea, we have the choroidal and ciliary body melanoma. Most of the patients came in with decreased vision. And also, as Dr. Guto mentioned about the diagnostic delays in about half of the patients, I think one of the reasons are the anterior located tumors or the diffuse type of the choroidal melanoma. And the most of the tumors are pigmented, and in some cases the tumors are likely pigmented, or what we call the amelanotic melanoma. And the tumor configuration could be a dome shape, a mushroom shape, or the diffuse type. And there are some risk factors for the uveal melanoma, such as the ratio factors, the sun exposure, and also the pre-existing nevus. It is, in my practice, I always see that medium or large size of uveal melanoma. It's important to look at the, to find the small melanoma as suggested by Dr. Shields. This is an anterior located uveal melanoma. So you can see it is quite a large tumor. And sometimes we need other examinations such as the MRI or CT scan to see the extent of the tumor. As you can see, the ciliary body is not involved in this case. And also I would like to mention about some of the differential diagnosis of the pigmented lesion, especially in the Asians. I think the most important one is the AMD, and also the metastatic tumor when you see a likely pigmented lesion. Yeah. And also, this is one of the most commonly used the classification for the uveal melanoma, the COMB study. And it is quite simple because it is classified as small, medium, and large. But as you can see, the tumor size is increasing, the survival rate is decreasing. And also, this is a little bit complicated by the AJCC. It also describes the tumor size from T1 to T4, but you have to notice that it also describes the if the tumors are growing to the ciliary body or without ciliary body. The B tumors with ciliary body involvement, but without extrascleral extension, and C tumors without ciliary body involvement and with extra extension of the ocular. So, and also up to T4. T4 tumors is any size with metastatic tumor larger than 5 millimeters. Yeah. So, and also the AJCC talk about the nodes involvement with regional nodes involvement. N1 has spread to the nearby lymph nodes, and M1A, M1B, and M1C according to the size of the metastasis. So it looks quite complicated, but if we can look at this slide, we can summarize as the stage 1, stage 2, stage 3, and up to stage 4. The important message here is with every increased stage, there are 3 folds of increased mortality rate. So always we have to keep in. You can put this slide in your ultrasound rooms, so you can always check with the size of the tumor and the extent of the tumor and see if the tumor is growing into the ciliary bodies. We do not have to memorize it, but just keep in mind that we measure the tumor size and keep the stage well. Yeah. And then this is a diffuse type of uveal melanoma. And when we do the ultrasound, it's about 14 times 3. And this is another one, the posterior located tumor is about 5 to 6 in thickness and about 10 in basal diameter. So it is a T2, these are T2A tumors. And also, and this is, I think this is the most commonly seen uveal melanoma in Asians, is posterior located. And then we do the ultrasound, it's about 6 times 12, and it is also T2A tumors. And then this is another anterior located tumor. You can see that it is quite a thick tumor, and it's about 9 in thickness. And then it is a T3A, it's 14 times 12 times 9. Yeah, both by ultrasound and also by the CT scans. I will skip this because another speaker will speak about this. I would like to thanks a lot for your attention. Thank you very much.
So we have 1 minute for questions. Anyone in the audience have a question? Okay, so I'd like to pose a question. You were talking about the AJCC classification, and you referred to, I guess, the 7th edition. A new edition has come out now. It's the 8th edition. But I'd like to ask our colleagues from Boston, maybe Dr. Kin or Dr. Gurgudis, in your practice, your daily practice with uveal melanoma, do you use the AJCC classification, and why or why not? Maybe one of you can answer just briefly.
Well, I was hoping that Dr. Kim would answer this question. She pushed the microphone. I don't use it. I don't see the point of it. I think that if we're going to make any kind of change regarding management, I would be inclined not to use it. Regarding the prognosis also, we have so many other tests, for example, one of the genetics tests. So, you know, if you do this, by far you are much better than any other classification. So it's not bad, it's good to have it, but for the clinical practice and, you know, to kind of get the results, I think that there are quite a lot of limitations.
Okay, so thank you. And thanks for explaining that to us, the classification. Now when you publish any major series on uveal melanoma, you have to classify according to the AJCC, as Dr. Chow has mentioned. So it's not easy to remember it, and as she said, keep it posted in your ultrasound room because you won't remember the nuances. Okay, thank you.